If something takes me an extra 3 seconds, I will easily spend hours to just get rid of that 3-second thing. It almost doesn't seem like it's a wise investment of my time, but it gets under my skin. It gets stuck in my brain. And I'm like, there's got to be a better way to do this. I mean, that's literally why I made MDCalc. And most of the other things I build is I'm actually building it for myself because it just bugs me. It just gets under my skin. And so I will build a little website or build a little tool that makes this thing that takes either too much time or it's too complex and tries to boil it down to its essence or down to a level that's way more easy for a human to get through and handle.
This is the Visible Voices podcast. I'm your host, Dr. Resa E. Lewis. In today's episode, I'm delighted to bring you my conversation with Dr. Graham Walker. Now, at baseline, Graham Walker is an emergency medicine physician in San Francisco, but he's so much more. Have you ever used MDCalc? Have you ever used the number needed to treat? Well, you should send a thank you to Dr. Graham Walker. Graham grew up in Kansas. He spent time in Chicago, Palo Alto, New York City, back to Palo Alto, and now San Francisco. We first met in New York City when I was an emergency medicine faculty member at St. Luke's Roosevelt. He was a resident doctor. He graduated as a chief resident, and on every shift when we worked, and it wasn't just me, every shift he worked, he brought in something that he had baked at home. Graham has always been driven by a desire to create efficiency and better evidence-based patient care. Thus, he founded MDCalc, the NNT, that's the number needed to treat. He's a co-author of the Physician's Charter for Responsible AI, and he's the co-founder of a new-to-launch online platform called Off Call. One of the impetuses for Off Call is that we need doctors who are smart, dedicated, hardworking, and committed to the profession. What sets Off Call apart is the commitment to physician-led data and a focus on both professional and personal aspects of medical careers. So what Graham has created with Off Call is an intention for salary transparency, job transparency, and an attempt to create networks and community within healthcare. Let's get to the conversation. What's one thing that you learned from growing up in the suburbs of Kansas City, that psychiatry thread in the household, and the fact that you loved making visits with your father to CompUSA?
Certainly the technology piece I learned from my father. He's the reason that I'm into tech. We had an Apple IIe and then a compact 286. And I remember going to probably CompUSA and getting a Intel inside Pentium processor 486. And it was a really big deal. So certainly that technology all comes from my dad. And he's still super active and passionate about kind of technology and gadgets and stuff too. And then I guess I would just say, I definitely felt like I wanted to get out of Kansas. Looking back as now an adult, Kansas and Overland Park, the suburbs where I'm from, I was very fortunate to grow up there. It had great public schools and it was safe and was able to, set me on the track that I am today. My biggest challenge with Kansas City, and it's become a lot more diverse now, is just how white and conservative it was. It's growing up in the 80s as a closeted gay kid certainly made me want to escape Kansas City and find a more diverse place.
Was there a psychiatry, mental health thread that supported you through childhood and teenage years?
I'm sure the way that my parents approached being parents was highly influenced by the fact that they were in the mental health field. People used to always joke that my dad was, oh, your dad's analyzing me or something. And I don't know that he was. I think he's just also even more introverted than me. I'm like a mixture of my parents. My mom's much more extroverted. So I'm sure the way my dad would approach things was certainly influenced by not just psychiatry, but just being a doctor. The old trope of doctors' kids really have to be extremely sick to not go to school. It's oh, you have a cold. Yeah, I don't care. You're going to school because we have a different thermostat of what an ill person is.
You shared that you moved to Chicago, you attended Northwestern, and you were a social policy major. What is that?
So social policy is like a public policy or a health policy degree. That's just what we call it at Northwestern. I was really interested in psychology and sociology as an undergrad, but it didn't have the hook of okay, these are interesting academic concepts, but like, how do you make change or how does that get implemented? And I was like, oh, wait, there's this thing called social policy that I learned about, and it's a major and it's in the School of Education. So I changed from the School of Sciences or whatever it was called to the School of Education and Social Policy, and took fantastic courses on just how do you set laws and policies and what are unintended consequences that have happened. And my focus was on healthcare policy. What is the current policies of the United States in terms of health? What are the impacts of those? What has worked? What has failed? Why have they failed? Really thinking about how do you make change in a effective way that does the most good for the most people.
It's interesting. We're building up all the bricks in your foundation to where you are today. You had a job after college in a startup, a single payer insurance startup. And simultaneously, to make money to support yourself, you started building websites. One was for repertory theater companies.
I knew I wanted to take a year off after college before medical school. I knew I wanted to go to medical school, but I had lived in the dorms all 4 years. And so I wanted to like have a year where I was like living in an apartment. And so, I moved to downtown Chicago and worked for Physicians for a National Health Program. They're a nonprofit and the only organization that's nationally working toward single payer health insurance, like a Medicare for all, essentially is the way that we try to brand it now these days. I had taught myself web design in high school, and then I had made some web pages during college. My improv group is called Meow. And so I made Meow's first web page ever. And so I would make little websites for people on the side just to make some extra cash because I think, PNHP, the nonprofit, I think I was making maybe $23,000 a year.
You sashayed to Stanford, where you were a med student and continued with building. This is the origin of MDCalc. And you famously talk about the Ransom criteria. You were asked to state the Ransom criteria, and you thought, why would I memorize that? That's not a good use of my brain time. And so you started MDCalc. For the audience members that aren't familiar, what is MDCalc?
MDCalc is a free medical calculator tool. We're used by about 2/3 of US doctors. It's a website, it's an app. We have an EHR integration now as well. And it allows doctors to answer a question they have using evidence. There's a great score that I really like that helps you figure out if somebody has gout, because often people will come in, especially if it's their first gout flare, all they know is they have a really painful red joint. Maybe they can't walk, it's in their toe often, sometimes it's in their knee or other joints. And it helps you decide if you need to stick a needle into that area that's already really painful. Test for gout crystals. There are some really nice tools that use some of the patient's risk factors, some other examination findings to determine, hey, is this likely gout? Or, hey, could I be missing something more dangerous if I get it wrong? So I find that to be a particularly helpful score as well.
It's a beautiful tool, and there are about 800 to 900 scores, words of 1 million users per day. And this is not just physicians. You have nurses using this. You have pharmacists using this, and it's quite useful. It's free. It decompresses that cognitive load of memorizing. Say a little bit more, the EHR integration. Again, our listeners may not be medical. EHR, of course, is the electronic health record. People probably are familiar with Cerner or Epic, or the fact that when you go to the hospital or the doctor's office, there's an electronic health record. Say more about the integration.
Part of MDCalc is often taking data either from the patient's medical history or from the electronic health record, say your oxygen saturation or your white blood cell count, and then inputting that information into MDCalc. You either pull it out on your phone or open the website, mdcalc.com, and the EHR integration just removes that step. It is able to pull the data directly from the EHR and insert it into the kind of calculator score to make it simpler and also safer. Sometimes you can imagine people have a typo or they add a zero or they fat finger something. And so it adds a level of safety. And then it also is able to take the result of the calculator and file it back into the EHR. So it's also one less step for the doctor to do. That information gets saved into the chart and the doctor can move on with their day.
It's very character consistent because you have said about yourself, inefficiency bothers me, and you like to get rid of hurdles.
Yeah, and inefficiency drives me totally insane that I will, if something takes me an extra 3 seconds, I will easily spend hours to just get rid of that 3-second thing. It almost doesn't seem like it's a wise investment of my time, but it gets under my skin. It gets stuck in my brain. And I'm like, there's got to be a better way to do this. I mean, that's literally why I made MDCalc. And most of the other things I build is I'm actually building it for myself because it just bugs me. It just gets under my skin. And so I will build a little website or build a little tool that makes this thing that takes either too much time or it's too complex and tries to boil it down to its essence or down to a level that's way more easy for a human to get through and handle.
From med school, you moved to New York City to residency. We know it as St. Luke's Roosevelt. It's now part of the Mount Sinai system with some other names. And you were full on with MDCalc, building, growing it, and then another productivity tool, user-friendly for healthcare workers, NNT. Can you just give us a one-liner about what is the NNT?
The NNT, the term, is an evidence-based medicine term, and the idea is it is a way to compare, so you could compare one drug to another, and the idea is it stands for the number needed to treat. If you have pneumonia, and I want to give you antibiotics, the NNT for antibiotics might be 10 or 20 or 50. That means that I would have to give antibiotics 10 or 20 times to help one of those people. When you learn that in medicine, it seems not possible. It seems like, oh, you have a bacterial pneumonia infection. Every single person that gets antibiotics is going to get better. Or the same with, like we all hear about aspirin for heart attacks or aspirin for strokes. You think, oh, aspirin saves a life when you give it for a heart attack. And it does, but it doesn't save every single life. Medicine and life is just so complex and complicated that you actually have to give, statistically speaking, aspirin or antibiotics, whatever it is, to numerous people in order to actually help one single person. And so that's the evidence-based medicine term. And in residency, we then created a website called thennt.com and tried to take really expansive, comprehensive reports called systematic reviews that are often 90, 100, 150 pages long and distill them down into bite-sized nuggets of information that a physician could then easily use to practice better medicine because they knew this tool was useful or this drug was helpful or not helpful. And we kind of gave it a traffic light. Green, this is things awesome. Yellow, hey, it could be good. Red, hey, this is actually probably harmful. And black is like, hey, this is absolutely harmful. You should not be doing this.
Yeah, it's actually a really beautiful healthcare design tool. And it's to allow us to provide safer, better, patient-centered care. Residency ended as it had to. And when you graduated, you were a chief resident, already exercising your leadership skills. You went to Stanford and completed a simulation fellowship, quickly moved to upon completing fellowship, your first job at the Permanente Group. You've held multiple leadership roles in the Permanente Group. You've now attended many, many meetings. You've been in many, many meetings. You have led many, many meetings. What would be your top pearl for how to run a good meeting?
I'll call back to my efficiency piece. Never have a meeting that could be an email. So could we just eliminate this meeting entirely? And sometimes that's possible and sometimes it's not. Certainly having an agenda for the meeting to know why are we doing this? What do we hope to get out of this conversation that we're about to have? Then I guess I would just say having everybody be punctual and ending the meeting on time as well. I think we as a society have all gotten more okay with everybody can be a couple minutes late and then other meetings run over by a few minutes. I don't love that. And I also, one example that I've seen that if you make a meeting on Google Calendar now, the meetings I think are 25 or 50 minutes. I think that's the default. You can set it to 9 to 9:30, but I think the meeting, if like a 30-minute meeting ends at 9:25 by default. And I love that because meetings will fill up the volume of time that you've allotted for them. And I love the idea of giving humans a break in between the meetings, and it also pads the meeting. If the meeting does need to go over, you're not then running into the next meeting being delayed or something like that. So I love that little default, little nudge behavior that hopefully makes things a little bit more palatable.
How do you think your colleagues would describe you as a leader?
I think they would describe me as passionate and energized. And certainly I use humor, like probably too much. And then I guess I would say authentic. I think I try to be very authentic and I try not to pull punches. I mean, I'm not like a rude dude, but I try to be honest when I think something is going to work or I disagree, or I'm always like going back to that social policy brain of, well, if we do this, that's going to break this other thing. I'm always thinking about unintended consequences. I'm always thinking about what will be really good about this new regulation or policy. And then I'm also thinking about like, oh gosh, this is going to suck for these other reasons. And can we find like an in-between solution that like, dials up the good and dials down the bad as well?
Yeah. I asked you about leadership because now you've had so many stages and experiences that you've had supervisors, you've had leaders. What would be one positive leadership tip you learned? You don't have to name names or institutions. And what was really something that was amazingly educational, but it was a horrible experience with a supervisor or a leader?
Okay, I'll do the positive one first. And I will name names. I mean, I say this all the time, but our CEO, Dr. Maria Ansari, and this sounds like so kiss ass, but she is just freaking amazing. And she is incredible at getting her leaders to like kind of operate at their highest level and let them be as efficient as possible. Because I think the way she thinks about it is, how can I clear roadblocks and hurdles to like bring everybody else up a notch? Oh, this is a problem. Well, let me talk to that person so we can get it taken care of. She used to be my local boss. She used to run the Kaiser San Francisco Medical Center. So I've worked with her for probably 8 years now. Every single one-on-one we would have, she would ask, Graham, how can I help you with your job? What do you need from me? Oh, you want to do a contest? Okay, yeah, I can fund the contest to fund some prizes so you can try to drive adoption of dictation tools or technology, whatever it is. She would constantly say, how can I help you be the most effective leader you can be, essentially? So I absolutely learned that from her. And I try to do that with people in the groups that I lead as well. I will not name names, and I can't honestly think of a specific individual for the negative example, but what often comes up in healthcare is what my friend Corinne McCleary calls the they problem. And it is that there is some rule or regulation or policy that is often not like clearly spelled out, that is just like somebody says you have to do it this way. And then when you try to dig into, well, why? That doesn't make any sense. Why would we do that this way in the ER? Well, they said you have to. And it's usually actually that word, THEY. It's usually not an actual human. It's a nebulous they. It almost like fully shuts down discussion.
Can you give a specific example?
Sometimes there are forms you have to fill out in order to get your patient to the next step in the process. You need to help get them to a custodial skilled nursing facility. You need to help them get to a shelter bed. You need to help them get to a dentist, whatever it is. Maybe you're told to fill out this form, but the form doesn't actually fix the problem. But the system has decided that nothing's going to get done until this form is filled out. Again, it's a nebulous requirement that somebody told you have to do, but there's no way to like fight the system almost or question the system or come up with probably the reason it frustrates me so much is it's inefficient and I cannot fix it. It's like the system has decided.
And is the negative aspect / amazing feedback as a leader that someone needs to take responsibility or someone hasn't noticed the inefficiency and removed it? Like, what about it is the lesson regarding negative leadership?
Yeah, thanks. I didn't get to that. The negative leadership is that the person making the decision is so many levels detached from the person doing the work. And it is very clear that the person making the decision has no connection to the work that they are dictating and mandating somebody else do. That's the piece, is understanding and respecting and being beholden to the frontline workers, particularly in healthcare, that are doing the work, and understanding that your rules are going to have consequences for people and make people's lives worse who are already having a rough time. If that makes sense.
It makes sense. And I'm going to tie into more quoting Graham Walker to Graham Walker. You can never over communicate a change being made in technology. And that you have to.
I love this guy. Who is this guy's freaking brilliant.
Yeah, he's pretty visionary, pretty visionary. Reminding people how far we've come, because they will complain. They will find and always be looking for and looking at the next annoyance. So you can never over communicate enough, because people will say, I wasn't told this. No one told me that. Wait a minute, what are we doing? Say more about this, and I'll tell you why this lesson in healthcare resonates so much with me.
It is really hard. And I think it's because physicians are busy. It's not that physicians are obviously dumb or bad people, or it is because physicians are so busy all day taking care of patients that communications my communications were typically around technology and changes to the EHR, for example. Those communications often got missed. And so I would go out of my way to communicate it multiple ways and disseminate the information as many times and as many media as possible. Because I get it. People are just busy, and nobody wants at the end of a long day to read another Graham email that he's maybe sending. And so I think that's the reason that you cannot over communicate things. Is honestly, it's just that healthcare workers are just busy people delivering care. And it's not like we're sitting in an office all day, and part of our job is to normally just read our emails as part of our daily work. Most of our job is just like seeing patients.
I learned in the point of care ultrasound world, building workflows, educating, QA, all the steps. You live in it, you speak the language. It's no big deal when there are updates, when there are changes. But for people that aren't living, speaking ultrasound all the time and looking at these workflows, it's one more thing, one more ask, one more task. And so the smallest change is actually overwhelming, and people are still integrating the change and the update that you shared 6 months ago. And so what I learned was sort of the judicious number and frequency of changes and updates to the workflow.
You hit on a really big point, Resa. The capacity that many people have to tolerate change, I think, has gone down. And then additionally, that's also why it's so critical that you get the decision right the first time, or get the whatever it is, the system, the policy, the whatever, the first time, because it is so hard to make changes in healthcare for many, many reasons. That's why it's really important that you get it right the first time, is that the change management is way harder than any new technology integration. The change management is the hardest part by far. I would take anything besides doing change management in healthcare.
This goes back to why I deeply believe that you are a healthcare designer. I am a healthcare designer. It's that iteration, poke holes, brainstorm, whiteboard, do it all up front, iterate, bring many, many users, definitely the end user, be that the patient, be that the caretaker, be that the clinician, to the table, iterate, so that when you spit it out and it's go live, it may not be perfect, but it's going to be so much better than had you not done those exercises.
I have not found, in my efficiency brain, I have not found a better, more efficient way to do this besides just like show it to a lot of people. In the technology space, you can build out these whole, we call them like testing suites. So you can write code, and then you can build out a whole testing suite that says, okay, if you click this button, the text should turn red every single time. And you can build out the tools to then test your code so that if you make a change to the button, it doesn't break the thing that makes it turn red. You can't do that in healthcare. There are so many human beings that use the electronic health record in so many different ways. The only way that I've really found to do this is just show it to a lot of people and ask a lot of specialists. I sit on our EHR steering committee, and that's the reason we have representation from pharmacy, from nursing, from I think probably like 80% of medical specialties, because it's just critical that you have as many people with eyeballs on this thing and looking at it and then testing it as well to make sure it doesn't break, like the nuanced thing that the anesthesiologist does that has literally nothing to do with what I do as an ER doctor.
Yeah. And I'm going to tie this into Off Call. There is a stat from the website. 50.4% of physicians reported feeling valued in 2023. That was up 4%. In 2022, 46%, which I don't think this is a great statistic. To be up, that's great. 2022 to 2023, we went from 46.3% to 50.4%. We're up a little bit, but still only 50% of physicians feel valued in today's healthcare system.
Growth mindset. Yeah, we're up. But the challenge is that medicine has become very corporatized. The other statistics from Off Call is that 80% of us are employed by somebody else. Often our boss is not a physician. I'm very fortunate that all my bosses are physicians, but often in the United States, the boss is not the physician. And so medicine has become very much a profit-seeking entity. And so it's hard to feel valued if you are viewed as just a widget producer, or just your expectation is just to churn through patients constantly, day in and day out, and to also have your autonomy reduced, that all of this 10, 15, 20 years of training that you've received leading up to becoming an attending physician feels devalued, in that you just need to do what you're told is kind of the message that a lot of physicians get, and not do a nuanced, individualized care plan for an individualized patient, which is the kind of way that medicine is taught. But you need to get in line and do things the way and be standardized with how everybody else is doing things for efficiency reasons, when we know that each patient is unique and different, and standardization and customization are always going to have friction in healthcare.
I'm going to make another thread through the life of Graham Walker. There's social policy. There was the blog that you wrote as an early adopter of medical blogs called Over My Med Body, which is such beautiful title, to the Physician's Charter. Tell the audience, please, about your blog and about the very prescient, very important Physician's Charter.
Back in 2003, when I started the blog, it was a web blog. That's where the term comes from, a weblog. And there were a small number of us physicians, many of whom I'm still close friends with today, that were blogging, that were talking about their experiences as a doctor, as a nurse. We called it the med blogosphere. This was before Twitter, and this was before social media and iPhones. And we were just finding ways to connect and share our experience. And I had decided, I want to blog my way through med school. I want to explain what it's like going from a human that's interested in medicine to like an actual trained human in medicine, and what the difference is between those two people. And there were other physicians blogging about being a surgeon or a pediatrician. And so we would connect with each other and talk, because again, this was before social media. We would comment on each other's blogs as a way to communicate with each other. And fast forward many years later, decided to create this thing called the Physician's Charter for Responsible AI. I think certainly the thread around this is I enjoy writing a lot. It helps my brain understand the world, and it makes my own beliefs and ideas clearer, because I have to put them out on paper for somebody else to read as well. The Physician's Charter was inspired, honestly, by ChatGPT. When it hit the scene in 2022 in November, I think, about 2 years ago now, I immediately was like, oh crap, this thing is going to take over the world immediately. Now, obviously it hasn't 2 years later, but I do think it's changed the world. And I strongly felt like it was going to take over everything. And I felt like physicians, AKA myself, needed to plant our stake in the ground. I felt like we needed to say, no, ChatGPT, we're not going to have doctors, we're not going to have ChatGPT take over medicine. And I'm sure part of it is a bit protectionist. I think that's probably the biggest criticism people would have. Oh, doctors just trying to like control medicine and it's paternalistic. But really, I mean, in my hope of hopes, it was that I didn't want patient care to be degraded. And I think patients deserve to have a well-trained human help them with their lives and their medical problems. And I was really worried that ChatGPT would just take over, actually would cause harm. We've all seen how Dr. Google can be very incorrect. And so myself and 10 other physicians, we all found each other on LinkedIn and decided, hey, let's like write this charter about how we would want AI to work in healthcare if we were in charge.
What's been its reception?
It's been really positive. There are a lot of organizations that are now trying to do this, which is outstanding. There's Chai, there's the AI partnership at Duke. And so there are a lot of people talking about this. So I feel way reassured that there are many physicians that are passionate about this. And it's not just like us 10 doctors trying to figure this out. So I'm hopeful AI will be deployed in a way that is patient-centric and keeps the physician and the patient at the center of everything. And AI can be a helper.
Yeah. I'm really glad you brought up LinkedIn. And in fact, I reached out to you at one point to ask you about what your experience was growing your voice, being an influencer on LinkedIn. And certainly you write freely your thoughts on AI, on technology, on health tech particularly. So where would you say the role is for LinkedIn and for other listeners that are looking to grow their voice in that space?
Resa, when I joined LinkedIn, I hated it. It was so bad. I left Twitter, where I spent a lot more of my time, in 2022 because Elon took over and brought a bunch of misinformation people back on the platform. And I was like, well, I'm not going to support. I spent a lot of time during COVID fighting misinformation. And I was like, I'm not going to spend my time on this place anymore if you're just going to have all these kind of ivermectin people on here. So I left in 2022 and then wasn't doing any social media for several months. And I was like, I was like, oh, I like writing, but I don't have a place to write. I wanted to share my thoughts as well. And so I was like, screw it, I'll like try LinkedIn. And LinkedIn was, and I think still remains like you said, super corporate and very like superficial and fluffy. And I hope that LinkedIn has become a little bit more like Twitter and a little bit like more like me. And it's not me that's changed, but I think LinkedIn has become a better place to share your professional thoughts. Everyone has their real name on there and people are generally professionals, right? I had like 25,000 followers on Twitter. Who knew how many of those were bots? How many of those were actually people that I cared about their opinions as medical professionals or technology experts or whatever? But on LinkedIn, I actually have a pretty good sense of who my followers are. And most of them are doctors, other healthcare professionals, and tech and AI people, which are the exact people I want to interact with.
Mm-hmm.
So in that way, I think it's been fantastic. I think each follower that I have on LinkedIn is way more valuable than the ones I had on Twitter, because most of the ones on Twitter were just anonymous, and I had no idea if they were people that I cared about their opinions at all or not.
Your voice. When did you realize you had a voice, and when did you start using that voice in any way, shape, or form you want to define it?
I think in one of my med school applications, I wrote that I had to come out as a tech kind of nerd person before I actually could even come out as a gay man, because at that time, tech was also super not cool to do. But I was really good with tech because I grew up with it my whole life. And so I think part of the reason that I found my voice is because as a gay guy, I had to get comfortable with being different and being other by society. And that was a hard thing to accept and learn. And you have to figure out how to be like, screw it, I'm just going to be who I am. I think that is actually part of the reason that I am able to have a strong, authentic voice, is because do I care what people think of me? Yeah, deep down, I secretly do. But there is absolutely part of me that had to learn the lesson that you can't care what everybody thinks of you, and you have to be okay with being different. Otherwise, you wouldn't want to live in your own skin. like as a gay person. And obviously being gay and different identities are way more accepted now. But, in the in the 80s and 90s in Kansas, it was not that way. Like being gay was literally the worst thing you could be. And so when I deep down knew that, that's a really hard thing to acknowledge and admit. And that one of the ways you can finally get to self-acceptance is being like, hey, I have to be okay with being a little bit different than other people, which I'm really proud of now. It's like, makes me who I am.
The Resa wrap-up. Special thanks to Dr. Graham Walker for joining me in conversation. To be clear, audience, Graham has been on my guest list for a very, very long time. The stars aligned. It was the perfect storm. And with the launch of Off Call, it was time to talk. So what can you do to be a part of the AI healthcare conversation? Number 1, read and follow blogs and newsletters. Number 2, take online courses. And finally, number 3, Google the Physician's Charter. Join the community by reading what physicians are saying about how to implement safe, accurate, and dignified AI tools. That's all I have for you this week, audience. See you next time. The Visible Voices podcast amplifies voices in the healthcare, equity, and current trends spaces. We are a production of the People's Media Network. Our team includes Dr. Giuliano DePortu and me, Dr. Resa E. Lewis. Please find me through my website and on social media, Resa E. Lewis, MD, or through the podcast, thevisiblevoicespodcast.com. Please give us a 5-star rating on Apple or wherever you listen to podcasts. Also, please be sure to share the show with a friend. The views and opinions expressed by the host and guests are their own and do not necessarily reflect the opinion of the institution with which they are affiliated or identified. Information herein should never be used as a substitute for clinical judgment or for medical advice.